Well, so if you look at any surgical intervention, surgery for not only in the spine, so the recent techniques have aimed at achieving the treating the targeted pathology by causing minimal disturbance of the surrounding structure. That is where minimal invasive has come in. But when we migrated from an open TLIF to an MIS TLIF, only virtual complication that we actually avoided was a less paraspinal muscle injury. I mean, in an MI TLIF, as you saw in all these videos, you still end up on the dura. There is a chance of dural. To handle the nerve roots, there is a risk of postoperative dysesthesias, neuritis, postoperative epidural adhesions, and all this can cause significant issues in the postoperative period. And that is where this lateral lumbar interbody fusions, or OLIF, that we are doing nowadays is a completely outside the canal approach. So we are not entering the spinal canal at all, not handling the nerves, not handling the dura. There is no risk of postoperative epidural adhesions, no risk of dysesthesia. And that is the main difference as far as OLIF is concerned. And not only this, as you see, the cage that we can put in an OLIF is the large cage that sits across the entire length of the vertebral body, across the apophyseal ring. And that is supposed to reduce the incidence where the apophyseal ring is the strongest portion of the vertebral body as compared to a cage that is placed in the central cancellous portion. And the risk of postoperative subsidence or the biomechanical strength of the cage is much better than in any other technique. Not only that, OLIF is the only technique where all the spinal structures are preserved. The facet joint, facet ligaments, there is posterior tension band, the spinous process, interspinous, supraspinous ligament, ligamentum flavum, posterior longitudinal ligament, as well as the anterior longitudinal. All these ligaments are virtually preserved completely, pristinely, without any damage whatsoever, only in this procedure, whereas in all the other approaches, some amount of bone or ligament resection. So now comes to the question, how does it act? How does it treat the pathology? And that is by indirect decompression. Now, because all these ligaments are preserved in a degenerative listhesis, just by distracting the interbody space, you can achieve ligamentotaxis, and that is why a complete reduction of listhesis is possible. Even in cases where there is a lumbar canal stenosis with disc space collapse, distracting the disc space reduces the bulging of the annulus as well as buckling ligamentum flavum, and that opens up the spinal canal significantly. And in degenerative scoliosis, because of uniform interbody distraction, as we know in degen scoli, it is the asymmetric disc space collapse that is the primary pathology. And because of uniform multi-level interbody distraction, this itself is sufficient in correcting the degenerative scoliotic deformity. Coronal imbalance can be corrected to a certain extent. And this is the basically the approach. It's nowadays we are doing a single stage lateral position OLIF, and the OLIF is an anterior to psoas approach as compared to the amount of disc space distraction and the foraminal height restoration or the lordosis restoration that we can achieve in OLIF is significantly better, as the literature also has shown, as compared to any other interbody fusion that we do. And this is one of the case examples. This is preoperative and postoperative MRI. As you can see, the canal dimensions can be completely restored even without entering the canal, even without doing any intracanalicular or intraspinal work. This entirely by means of an indirect decompression. So this is again one more example. So even in degenerative scoliosis, which actually is not the topic, it's very easy to do a multi-level OLIF just by jumping from one disc other disc space, rather than doing an entire repetition of the work. But when you are doing an MIS TLIF, the entire repetition has to be done at each level, whereas in OLIF it just takes an additional 30 minutes, 40 minutes level, where you can just jump from one space to the other space, and a significant restoration of coronal balance, even in very, very severely deformed cases, can be achieved without doing any intracanalicular work. And usually these kind of deformities, earlier to reduce with an open or an MIS TLIF approaches, were used to take a long time, and the amount of correction that we can achieve is also significantly much better. OLIF is not only that, OLIF can be used or combined with other techniques as well, like say for example in this particular case where there is an acute L5S1 disc fragment. So you can actually do a lateral position endoscopy, again in order to remove the acute fragment at L5S1. Apart from the OLIF, nowadays we are even doing endoscopic assisted discectomy in OLIF procedures where there is an intracanalicular acute disc fragment or there is a significant canal stenosis, as you can see in this particular case. So this is a short video that is showing that is the route on the opposite side. This is again using 3D navigation. We can exactly localize where we are. You can go using an endoscope and we can actually remove the disc fragments, even acute fragments, from within the canal and open up the entire canal across the length, even in an, because the skin, usually the pendulous abdomen skin, allows a significant amount of mobilization or angulation of the endoscope which we can visualize the entire posterior annulus. And literature has shown that compared to MIS TLIF, OLIF has achieved significant restoration of disc height and lumbar lordosis. The operation time, the estimated blood loss, everything has been reduced as compared to MI TLIF approaches. These are some of the other papers that I've shown. I will not go into the details. And let us not even discuss about L5S1. We know the limitations of posterior approaches in L5S1, a wedge-shaped vertebra. It's how difficult it is to put in a large cage. I know nowadays the 12-degree expandable cages are coming in a big way, and until they are available in an affordable or in a routine way in India, so putting in a large cage either takes away your lumbar lordosis at L5S1, the segmental lordosis is lost by putting in a large 6-degree cage, and it's also difficult to put in a large wedge-shaped vertebra from a posterior approach where the posterior angle is, the disc height is significantly less than the anterior disc height, especially L5S1. So this is where even an OLIF at 5S1 level has got a significant advantage in maintaining, restoring or restoring the lumbar lordosis. Again, I'll just give an example. This is one of our own TLIF, MIS TLIF cases where we have significantly achieved a good reduction, but again, the lordosis restoration may not be adequate, and the same thing can be achieved in a significantly better manner by using an OLIF 5-1 approach. So I'm not telling that OLIF is all about glory and gain. So there are significant advantages for OLIF, as I've already mentioned throughout the talk, but yes, there are significant limitations as well. OLIF is not feasible whenever there is an abnormal vasculature, there is a prior retroperitoneal surgery. If it's an immobile segment, as we already discussed in the panel discussion, severe facet arthrosis, chronic calcifications, ALL shortening, where the feasibility or the possibility of distracting the disc space itself is reduced, OLIF may not be a suitable option in cases. Of course, severe central canal stenosis, patients having rest pain due to the severe central canal stenosis. I've shown a couple of cases, but I am not sure that the literature or the number of cases that we have done are significant enough to justify doing all these cases with a retroperitoneal approach. So significant superior articular process osteophyte, all these limit the efficacy of OLIF in achieving that indirect decompression that is required to mitigate the patient of their symptoms. With this, I would like to say thank you.